everyone. Thank you for joining us for this panel session, Innovative Technologies for the Healthcare System. I am Claudia Kriviak, Vice President of Corporate Planning and Development at the Ontario Centres of Excellence, and I welcome you to this session on innovative technologies for the healthcare system. Innovative advances in medical devices and processes can enhance quality of care, as well as efficiencies and cost effectiveness within our healthcare system. This session will provide key insight into how hospitals and the private sector are collaborating to provide continuous improvements in client care. It is my distinct honor to introduce our moderator for this session, Dr. Anne Snowdon, Chair for the International Center for Health Innovation at the Richard Ivey School of Business at Western University. Dr. Anne Snowdon has dedicated much of her career to producing research and advancing innovation that will improve the health and well-being of Canadians. As Academic Chair of the International Center for Health Innovation at Western University's Ivey Business School, Dr. Snowdon leads the center's work to drive health system sustainability and productivity. Dr. Snowdon has published more than 70 research articles and received over $7 million in research grants. She holds a PhD in nursing from the University of Michigan. She is a Fulbright Scholar and was awarded the Social Sciences and Humanities Research Council Doctoral Fellowship for her doctoral research. Thanks, Anne, and now over to you.
Thank you so much, Claudia. It is a pleasure to be here, and I'm going to start by challenging everyone in the audience and the panel to think about ways those incredible technologies that the keynote speakers spoke of might be leveraged to really accelerate innovation in healthcare. Healthcare is certainly one of the most highly valued sectors in Canada. I often joke, Americans carry the flag and patriotism, Canadians hold up their healthcare system. So our panel today is going to speak to some of the challenges and opportunities for health systems in Canada to really think differently about innovation. How do we get those phenomenal technologies into our health system to achieve health, wellness, and value for the Canadian economy and for Canadians nationally? So with that, let me introduce my illustrious panel. Our first panel is Shirlee Sharkey. She is President and CEO of St. Elizabeth Healthcare, an extraordinary healthcare organization known for social innovation, very strong financial performance, and pioneering practice to support people's health and wellness in communities. As an award-winning, diversified not-for-profit, St. Elizabeth delivers more than 6 million healthcare visits annually and employs 7,000 people providing nursing, rehabilitation, personal support, crisis intervention, research, and consulting services. So with a century of experience and powerful vision for the future, St. Elizabeth is committed to empowering families, clients, staff, championing compassion, pursuing high quality and value, and as an organization firmly fixed on honoring human experiences in healthcare. So Shirlee, you have much to share with us. Our next panelist is Tiziana Rivera. Tiziana is the Chief Nursing Executive and Chief Practice Officer at Mackenzie Health. Tiziana provides strategic leadership for the development and implementation of a shared vision for professional practice, nursing, and all disciplines that will lead to innovative care and the development of care delivery models that will efficiently and effectively impact quality of care and health outcomes for the people they serve. As Chief Nurse Executive and Chief Practice Officer, she strategically influences practice by promoting and creating settings that encourage reflection, learning, and consistent application of knowledge and research into practice. And to change up from the provider organization, next on our panel is, I'm going to wing this one, Sachin. Sachin Aggarwal. He is with PatientOrderSets. PatientOrderSets is a phenomenal Ontario company that started by, I believe it was Chris O'Connor, who really went after some very strategic opportunities to create standardized, strong evidence-based practice tools for providers in hospital settings in order to achieve much greater quality outcomes and reduce the risk of error. PatientOrderSets is a company that started, and when you speak to Chris O'Connor, one hospital at a time in terms of getting this model adopted. They are now in several health systems, entire provincial health systems, and many other countries, including the Middle East. So he has much to share with us, Sachin. Thank you for joining us. Baksi. Gary is Vice President of Sales and Health and Wellness of NexJ Systems. Gary's leading NexJ's navigation of Ontario's healthcare ecosystem in advocating for the value of solutions that activate patients and their advocates in participating in their own care. Gary is a business strategist and a business builder with over 20 years of experience in complex enterprise sales across 5 continents. NexJ's done a lot of very interesting work on digital platforms that help people self-manage their chronic illness conditions. And last, but by no means least, is Jesse Shantz. He is Chief Medical Officer with OMsignal. Jesse is a Chief Medical Officer that has a passion for wearables. So wearable sensors started when he saw the potential to measure orthopedic patient outcomes with wrist-based wearables, a program he started at the University of Toronto. Soon after that, he became one of OMsignal's first testers, wearing the shirt to measure stress during trauma surgery. And now he's on the inside shaping how OMsignal will define performance and fitness for users. He's an adjunct professor at UCSF and an orthopedic trauma surgeon in San Jose. He also has fellowship training in sports medicine from the University of Toronto and has completed his MBA at the Ivey Business School. So I'm pleased to welcome the panel, and what I would like to do is begin by asking the panel some key questions around innovation adoption in health systems, and what we'll do is then open it up for dialogue and discussion with the audience, if that's okay. So let me begin. I told them this is a tough test, and none of them have the questions ahead of time, so it should be fun. Canada is a country, as you all know, of phenomenal strengths. We're the second most highly educated workforce in the world. We are 4th among the top 4 in creating new knowledge, new devices, new technologies, new sensors, many of which you heard about earlier today. But we rank near the bottom in our ability to take those new technologies and embed them in the DNA of our health systems to really achieve value. So let me turn to the panel and ask the question, why is it so hard to integrate these innovative new technologies in our health system? So let's start with the providers, Shirlee at St. Elizabeth in the community and Tiziana at Mackenzie Health. What are those challenges in providers? How do health systems and organizations adopt and get these technologies from those labs and small companies into health systems to help our patients?
You know, it's a great question, and there's a couple of areas that I think are significant. Culturally, as we all know, within healthcare, we want it perfect the first time. We don't make mistakes. So clinically, we're wired that way, and a lot of innovations and new devices don't necessarily fall into perfection, no risks, and magic. It exists. So there's that environment that I think for us as an organization, we took many years to try to change that up and know what it meant. If we were going to be innovative, as we all know, we were going to make mistakes, and our mantra is always lots and lots of little small mistakes. So that's sort of the culture piece. I think that there are some difficulties with adoption too, because the starting point is off, meaning the product's already developed and we're brought in at the back end of it, versus working together, bringing the inside and outside together to look at what are the ideas, the opportunities, and actually working together for the product development or for testing and prototyping, so that by the time you move to adoption, it's like a relationship. You know, we're trying to ask why everybody isn't immediately getting married when you haven't even had the first date, and to work it through.
So we should maybe be thinking of the concept of speed dating, Shirlee. Let me just leave that one with you. Tiziana, from the hospital perspective,
from a community,
help us out.
Yeah, from a community hospital perspective, from looking at adopting innovation into the practice setting, just building on Shirlee's comments, It is really challenging from a financial perspective to look at where do we allocate base funding dollars into something that's going to be creative and innovative and really make some substantive changes into the healthcare system. I think the funding piece is one aspect of it. Change is very slow. We're a risk-averse culture that if we're not sure of the outcomes, making sure that we have the right ROI in relation to patient safety, creating quality environments, and that it's not going to throw us off from a budgetary perspective. I think that those are some of the barriers. Also looking at how do we change all the processes of care to ensure that we get 1,000 staff to do something differently. We're dealing with, in our organization, we have about 1,000 registered staff, registered nurses. If we want to adopt a technology and implement it into a healthcare system, we're looking at a lot of human resources that are needing to get the uptake, the education, the training, changing every single processes of care to ensure that that gets adopted while we're providing safe care, which we want to mitigate any risks while we're adopting that innovation into our practice setting. So those are a couple of real basic things that present us looking at doing the care, but also looking at how are we early adopters of some of these innovative technologies.
So on one hand, it's really getting to know and understand and form very critical partnerships with people developing these technologies, but even if we do that really well, Tiziana, it's a long, slow process to move 1,000 people in a new direction because they actually have to use those technologies, embed them in their practice, and change how they do things. So it's not an overnight.
It's not, and one more thing I'll mention,
Okay.
It's all about timing. Timing
yes.
is everything. We're in the middle in the midst of creating a new hospital in Vaughan, and the timing is just so for us. So there's an appetite within the organization to take on an innovation agenda because we have a large project on the go. So timing and all of these factors, I think, are enablers.
Okay, so on the other side, Sachin and Gary, from the industry side, small, medium startup companies or medium enterprise companies, you've been down the road of having to get a phenomenal product into the health systems. What are some of the challenges you've faced now and positioned against what providers are suggesting makes it harder?
It's the other side of exactly what the other two panelists are saying. I think it's a part of our DNA. If you look at a very traditional technology adoption curve, you've got your very early innovators. Those are the people who will adopt technology the moment it becomes available. And then you've got your early adopters who tend to follow the early innovators. And then you've got a big majority followed by the laggards. I think in Canada, particularly in healthcare, we see very, very few people who are in that early innovator category and very few organizations who are in that early adopter category. And as a result, there are very few opportunities for startup companies to be able to make inroads. And part of that just has to do with our DNA, our culture. We're very risk averse. But part of it has to do with the fact that we come from a history of not competing in the healthcare system for consumers, in this case, patients. And as a result, when we're not competing for patients in our healthcare system, we're not competing for dollars. And part of that, I think, is what's driving our risk aversion. We want to get everything right, as you said, the first time. As a result, it's very difficult for small companies. Now, that is changing. It's changing fairly rapidly. It's changing in Ontario fairly rapidly with some of our public policy changes over the last couple of years, which are actually creating some real opportunities for small companies, particularly in that early innovator and early adopter category, the ones that are not necessarily the large organizations, but the ones that are the smallest organizations who are facing flat budgets, but reducing funding from the province. And for those, they've got no choice. They've got to innovate. Yeah.
So, Gary, do you want to add to that?
Yeah, thank you. I think the point being that, and it was in the talk previously, that startups are the ones that are more able to take risk and innovate. Large firms, companies, systems, payers have a process to protect and a lot of momentum. So if you try to look at what is the genesis or the harbinger of a disruptive change, it's not something that's comfortable to the people that are in the system. And frankly, many of them fail, so it's hard to predict which will work and which don't. It's like Gretzky had this innate ability to go where the puck is. Well, we don't all have that. So when you have 3-year RCTs and things that are table stakes to establish evidence, how do you manage all of this? So one of the things that we're looking at is the difference between the investment in the clinical side, and it's sort of to your article, versus the consumers just demanding that they be included in it. Now, they don't have the medical degree, but they do have a huge part. Only 10% of a person's health status is related to their medical services and systems. 40% is tied to their behavior. They have a huge amount to contribute to their behavior, and their social circle can help coach each other and inspire those changes as well. So that's an approach that we're hoping is disruptive and converges with wearable devices and things that are coming shortly.
So that's a great segue, Jesse, into the consumer side, but I am going to come back to the culture, because that comes up over and over again. But Jesse, you're a trauma surgeon, and you've created a new innovative technology, but you've gone the consumer side of the house as opposed to embedding these sensors into your practice or into health systems. Can you share with us how that works and where you see some of these challenges and maybe where some of the solutions are?
So yeah, I actually started at OMsignal because we were looking at the applications in the healthcare system and looking at the sensors that we have as a medical device potentially. And I think that partly because I know the culture of, particularly on the physician side and just in general on the hospital side. My dad was a hospital administrator, and I went through medicine. I went to Ivey and started to understand a bit more about it on an academic level. It's very difficult to change that culture. It's also very difficult to know who your customer is in the healthcare system, because like for instance, our shirt has an EKG in it, a 3-lead EKG, which could be used as a Holter monitor if we did the appropriate testing. But who's our customer? Well, it's not actually the patient. It's potentially the cardiologist who would refer the person to have that, but it may actually be the clinic where they go, because the clinic may actually derive revenue from putting Holter monitors on people, that's the way it works in the States. And so therefore, if you say, oh, I've got something out of a box, like basically Netflix for Holter monitors, then you're going to get into trouble with the cardiologist because you're cutting into their revenues. So I actually said, probably not the greatest idea to go into this as a medical device company because of all of the complications. Let's simplify it and say, let's make a consumer product that's really going to bring people a lot of joy, but has basically the quality of signal that you'd expect in medicine to be able to help people with their performance right now, to branch out into other markets later on, and then actually, because consumers demand it, push it into the healthcare system as something that can be used by doctors, because patients expect them to use it because they have the data, and we are able to give the doctor something that they can understand as well in terms of basically continuous biometric signal.
So you're actually taking the product into the consumer market with the plan that consumers will just walk into their physician or provider and say, figure it out, Shirlee or Tiziana, I want you to be using this EKG tracking sensor, whatever it is, so that you and I can have a different conversation.
And to be honest, people do it right now. They bring in pictures of things, they bring in the Dr. Google thing where they'll bring in stuff printed off the internet, and that's a lot of information to crunch. And what I think my role going forward with OMsignal is going to be, as we mature as a company, will be to actually create the data analytics tools to be able to bring value to physicians as well when the time comes that the data is there for them. And there are companies like Validic out of North Carolina that are actually aggregating all of these different sensors that people are wearing on their body and packaging that data and actually pumping it into electronic medical records now to be able to be used at some point. And then institutions will be able to create their own data analytic functions to be able to actually take that data from multiple sensors and use it for better patient care.
So, Shirlee, You lead a very large organization looking after these consumers and their families at home, in the communities. How do we create this interface between these amazing technologies for consumers who do actually want to achieve health and wellness? How do we marry those two, the consumer technology side with the formalized health system side?
Well, I actually think Jesse's strategy makes a lot of sense, because we as a healthcare organization, that's exactly what we're looking at. Direct to consumer and capitalizing on the technology and the opportunity that exists there, and how that will actually impact the speed within innovation and changes that'll take place in what I would call the healthcare system. I think it's very difficult in the acute care, or I would call location-specific health structures, to leap into these kinds of innovations we're talking about. And we, several years ago, whether through luck or genius, knowing that we had a window in the lives of people. Notice how I phrase that, not in their health care or their home care, a window into the lives of people's behavior, interest, access to information. We right away thought, we've got to capitalize on this, and rather than have their experiences intersect with us in the health system, we have to figure out how we intersect in their lives. And a number of things we've looked at to enable them and look at things very, very differently has been actually outside of the government-funded healthcare system and in the direct-to-consumer. And I think timing is everything, because now with technology, the empowerment of people, their interest, there's going to have to be if it's not a blending, it's a coming together of synergy for what we're trying to do in the public-funded health space, and then what consumer behavior is all about, and to capitalize on that. I think for too long, healthcare has been in a bit of a bubble. It's been protected. Now it's just too big a force. The economics are there, and the demographics are there that are just changing it up. Fitbit used to be an exception. We're now looking at getting our 7,000 employees these monitoring devices. Why? So that they're champions of the kind of technology we're trying to have the uptake for. And if they're not embracing it, how could we think clients and people are going to embrace it? So, it was a bizarre kind of thought we had. You typically go mugs and vests and coats, and then we just said, passé, how do we change this thing right up to get the Fitbits? And it's the energy that will bring it together.
So to some degree, you're touching on what His Excellency, the Governor General mentioned, the biggest danger is complacency. And to some degree, health systems, we really haven't had to change all that much until now. We've sort of hit the sustainability, fiscal challenges that we've actually never seen before.
Yep.
Well, at the same time, you've got this massive development of technologies we've also never seen before. So to anyone on the panel, how do we start to shift the culture of health systems, which you've all said, really tough to access from the industry side? Jesse went completely the other way on consumer side. Health providers saying, yeah, it's a long, slow climb getting people to change and adopt technologies. What are some of the key opportunities to shift the culture so that industry, entrepreneurs, startups have an opportunity to work with their colleagues in health systems to say, let's achieve it together? Sachin, you look like you're dying to answer that question.
It's both the carrot and the stick.
Yeah.
The stick being funding. It's got to hit their bottom line. And as soon as the healthcare system has to compete for dollars, they have to compete for patients, they have to compete for quality, you'll start to see adoption of new technologies. On the one side, that's the stick. On the other side, it's the carrot. And the carrot in this case is we've got to change our culture to a culture that accepts a level of risk-taking and actually celebrates failure, right? We have to celebrate failure. We have to talk about failure. We have to be public about failure, and we have to be willing to take risks and try out new things, be it on a small scale or a medium scale, but we have to be able to do that. And now, you're not going to change that overnight, and so I think you've probably got to have public support for that. whether that comes in the way of funding programs that show demonstration projects or innovation projects or something of the sort. So there's a way to shoulder the burden and help a transition to a culture that accepts failure, that celebrates failure, but I think it's both. It's the carrot and the stick.
Shirlee.
I was going to add a couple of things. In the last few years, with the real direction towards social enterprises, which haven't necessarily been anchored in the health space. And as we know, they've been anchored in everything, sort of oceans and all kinds of housing and social issues. But more and more, there's a real understanding of working closely with the entrepreneurs well before they actually get into the actual creation. So you're working with them as part of the idea generation. What St. Eliz has supported Impact 8 out of the Mars Social Innovation, which is an amazing way we were able to, in partnership, set the theme of aging well at home. And we have all these entrepreneurs coming up with new ideas at the very early stage, working with us to make sense of these solutions. I think it has to change up. It's not just going to be funded and here it will be. It's actually figure out how to work with people outside of our organization and actually outside of healthcare, and bring them into the healthcare system and work together and mentor and make some sense of that. I think the second piece, and this is where I would agree, is how do we, both from rewarding, funding, and actually with procurement and things that we do, create the environment that allows for the uptake of the innovation. So I think it's a whole journey where we have to figure out idea generation, pre-market space, the uptake of it, you know, the vehicles that then bring them into the system, and then the actual clinician. And it is a journey that needs, though, triggers at every point. But I think if we don't start at the beginning, working with the people to create the ideas and make some sense of it, you don't have a chance in those other stages.
So you're late in the game when you've already got the technology and you said, okay, Shirley, I got a great idea for you. I just don't know what problem it fixes, but it's a great idea.
Yeah.
Tiziana.
One of the things that we ask a lot of in our organization is what problem are we trying to solve?
Right.
Because we'll have a lot of vendors who will say, you have to have this product. This is the shiny new thing on the block, and this will solve this problem. But we don't have that problem. We have something else. So it really is working in a really collaborative manner with leaders within organizations and partners to look at what are some of the main issues that you're dealing with, that your staff are dealing with, that cause you to, you know, keep you up at night. That piece of it as well is also having vendors ask us different questions. So, you know, case in point, when we were making a major capital purchase within our organization, we asked the question, can we move beyond the transactional business model that we have? We give you money, you give us your product. And it caught them a little off guard and say, what are you talking about? Well, we haven't done that before. And we're, you know, it's a large international company. We haven't done that before. What are you looking at? What are you thinking about? And it really was around that simple question that got us to a different place less than a year later. And it was just because you thought of, you know, many companies think of us as, you know, healthcare, we can't spend, we've got, you know, tight budgets. But just exploring what's possible is another way to get beyond our traditional ways of thinking, that we can't be early adopters of technologies and emerging ways of doing things differently that can be cost effective and good for patient care.
Jesse, did you want to add? Yep.
So there's something really interesting in this. Like, as an orthopedic surgeon, I use implants all the time. And when you think about it, the big companies who are supplying those implants, the problem with negotiating with them in Canada is that they tend to be distributorships. And that's where I think the small and medium enterprises here, where they're actually based here, can have a lot more ability to change their business or change their product for like a Canadian market, or configure it for an individual problem. And that's part of knowing who you're talking to. And then the other part of knowing who you're talking to is that if you're talking to a Canadian company who's going to need to be funded like early on, then the issue of talking to them and giving them Canadian sort of solutions is that getting funding in the US is then very difficult. Because if you come with a business plan that sort of puts forward a business model that is based in Canada business model, and you require funding from like outside of Canada to get this going, or you have a plan to go to the United States market, then it's very difficult to sell that. You have to be, I think that as a collaborator with those companies, you have to really be aware of that and make sure that you think with an American and a Canadian hat on to be able to sort of give them that story to tell an investor, potential investor from wherever they go to, Boston or San Francisco, wherever they go to.
Let me ask the audience to please join in the discussion. If you have a question, comment you'd like to pose around any of these items, by all means just come to the microphones and we'll engage you in some of this discussion. But while we're waiting for you to think of those incredibly hard questions for the panel, I hear a lot about what the companies need to do in terms of working with the health system, but how exactly would some Ontario-based company know who to talk to, when's the right timing, how to talk to them, and how to build that collaborative partnership you're suggesting is so critical? I hear that question all the time, so I'm opening it up to the panel, and then we're going to go to the gentleman at microphone 2. So Sachin, do you want to take a shot at that one?
My recommendation is go small.
Small meaning, what would small look
Small
like?
means small healthcare adopter. It means the person who has the most acute challenge. They've got the smallest budgets, and the problems to them matter a great deal. So we have one core product, which you spoke about earlier, but we have another 6 or 7 products that we've launched in the last year. And every time we need an early adopter, someone who's going to test it, and somebody's going to adopt it quickly, we go to a small-sized hospital, someone who is less than 100 beds, right? We get very quick uptake, we get an audience very quickly, and we get very, very little bureaucracy. So my recommendation is go small, get a reference client, go to their peers, get secondary and tertiary reference clients, and move your way up the market.
Interesting. Microphone number 2.
First of all, I'm Dan Wasserman. I'm from Venture Lab. I'm the EIR in charge of the healthcare ecosphere, which I think some of you have probably heard of. That is the partnership that was formed with Southlake Regional Hospital, Innovation York, and Venture Lab. And where we change the paradigm is what you folks are really talking about, which is asking the healthcare providers, what do you want? What are your needs? And in that way, we were able to establish a mechanism whereby we can evaluate in conjunction with our partners what those innovations are and how to get them into the actual systems, into the clinical environment so that they can be refined and meet the needs that you have said. I agree with Sachin about size because that definitely has a bearing and there's only so much bandwidth within the hospitals themselves. The cluster model that we've come up with has now been replicated in Niagara region and is underway in both Mississauga and in Ottawa. So the point is that here's a model. We've been in discussions with OHIC and people are becoming aware of it. The point is that here is a way that we can start to pull together what all of you have said and look at it on a holistic basis across the province, potentially across the country, to really find a way for innovation to meet the healthcare needs. The bottom line is that we want better patient outcomes at reduced costs for those outcomes. How can we achieve it? And for that, I really compliment the panel on what you've said.
Thank you so much. Shirlee, do you want to respond?
You know, the only other thing I'd add to that from idea generation and what people need and want and what's the problem, we've really expanded that well beyond what we think as providers and clinicians what the problem is. And it's scary. With our 7,000 through soapbox, we're doing that with what's the problem. And I sometimes now am going, I don't want to know. Then you add that with...
Careful what you wish for, Shirley.
We didn't stop there. We really now want to... What a crazy thought where someone said, how about you ask the people who are receiving the care or who are experiencing the problem to let us know what they would like. We kind of went, hey, it's an idea. So now we're trying to, and what's wonderful with social media, whether you're using whatever mechanism. We at the moment are implementing Soapbox. What I love about it is it's no longer the loud voice, or it's no longer the most empowered. It really is everyone, and you can, you know, design it, control it, and vote and make some sense of it. And that, I think, is absolutely critical to figure out and change up the innovation and the engagement platforms that we can use to engage people. I mean, to this day, I still see the focus groups and the this and that, and I just sort of, you know, go, oh my goodness, we have to innovate how we're innovating and innovate how we get those ideas. So that's the only thing I'd add, is that they're not always the same, which has been surprising. What people want and desire and what we think as clinicians and organizations are the problems we're solving. And to try to make some sense of that is interesting on its own.
So a couple of points that starts to emerge. Canada is considered a country of pilot projects. We are incredibly good at coming up with very good ideas. Venture Lab's probably one of them, or is one of them. The question is, it's only available in that neighborhood in the province. How do you scale? How do you get from the great idea, the proven impact, the evidence that it works, so that every organization in a health system has the same opportunity to achieve value for the people they serve? It's not just Venture Labs outcomes, or it's not just Shirlee's brilliant ideas, which are almost every other day in that organization. It's how do we create the environment, or the ecosystem perhaps, so that it moves across systems and every person in Ontario, in this case, has an access to those great ideas. Tiziana, and then I'll go to Gary.
Sure. One of the things we're doing is really wanting to partner with an academic center to look at doing some rigorous evaluation. So a third-party evaluation of the work. Really easy for me to sit here and say that the innovations that we're doing within our organization are first in Canada, and this is the ROI, and this is the impact it has on patient care, safety. When you have an academic partner that'll come in, work with you, and really bring that kind of rigor from a research and evaluative perspective, it elevates it to a different level. And when you get to publish and disseminate it in a different way, it brings a level of credibility that provides that evidence to other people who perhaps control the funding that will allow it to get beyond your organization and into other settings. I think the academic piece is one of them, but actually having true results from what you're doing, I think, is sharing the story is another piece of it, because subject matter experts in different organizations share the stories, and then there's just the grassroots kind of uptake. Some of the ones that are more expensive to implement need that kind of rigor.
Gary.
So to your comment about how do you take this pilot and 13 different EMRs just among family doctors, whatever the math is, how many different HIS systems and how many different provinces with different sets of rules, it's seemingly impossible. One thing that we did, which I hope falls under the category of learning or making mistakes, is to realize that the integration point to point is just too hard to do in real time. You can do it for specific things, but how do you change the paradigm, build something, and then they will come and have the faith and confidence, which requires fairly deep pockets, frankly.
Yep.
So in one case with point of care education, we understand 80% of what happens in a patient visit with the patient from a practitioner is forgotten. And of that 20% that's taken in, 50% is misinformation. So we now have an approach with Liberate that allows infographics and a recording of the session. So no secret notes being taken from the doctor. It's just that communication session is now shared. So when they get home and realize that they've got some terrible issue to deal with, that they can replay this simply. It's free for doctors and it's free for patients. So it's a little bit like Facebook. We don't know what we're building, but you have to have that as a foundation to go to a practitioner and say, now what would you like to add to it? That's a baseline. We have people talking. The privacy is dealt with, the patient's in control, they choose who's in.
So you start to give them tools for the formalized system to start to engage the consumer.
And then those will find value to add, such as coaching, and they'll say, great, now I can move, I don't have to worry about all this 2 years of mess with IT to even start the first step.
Yes, thank you.
Thank you. My name is Sarah Thorne. I'm from Decision Partners, and I'm also a member of the, believe it or not, Energy and Environment Board for Ontario Centres of Excellence. But I'm really interested in healthcare, and I'm doing a bunch of work in that space as well. What I wanted to ask the panel is, given that we're talking about major culture transformation of the healthcare system, but also the cultures within every one of our organizations, and also the culture of consumers and patients who probably more or less think of themselves as consumers most of the time. Why are we so reluctant to use leading practice social science in designing and implementing this transformational work?
Can you give us a bit of an example in terms of social science? Because I think I know what it means, but it may be different for different people, Sarah?
Well, one of you mentioned that 45% of the health outcome for an individual is based on behavior.
Health behaviors, yeah.
On health behaviors.
Yep.
So why is it that it's such a struggle to incorporate decision science, behavioral research, and thank God that you recognize, thank you for saying that there's things other than focus groups, which even the inventor of focus groups has now stepped aside. He's completely wants nothing to do with them because they're being misused.
Sure.
They're not doing what they were designed to do. But why are we not using behavioral science tools, research tools, to help with this cultural transformation and to help you folks with engaging employees in being early adopters, and you folks in understanding what, not just what patients want and need, because and consumers, they may not know, but how they would shape their behavior if they had access to some of your tools.
Thoughts? Yeah, Gary.
Of the 7 payment models I know in Ontario for family doctors, the rostered one, which would be the family health teams, they now, like the Japanese many years ago, have an interest in minimizing the number of transactions, not maximizing them. So they are an example of something that's been enabled that wants to make sure you follow your prescription. Exercise, eat better, take your pill. These things are not easy to do, or else I would be in better shape and my wife would be happier. You need support. So I think we're changing, but it's partly the system that reinforces. If it's a transactional system, then it's not driving a behavioral system.
So with a fee-for-service model, is this maybe where you're going, the built-in incentive is volume. And Jesse, I'm going to ask you this next because it's one of your discipline. Your discipline is actually in the center of this. It incentivizes volume. The more patients you see, the better it is. But it doesn't actually incentivize outcomes and whether that person achieved their goals. So from a physician perspective, what do you think, Jesse, given that you traverse the entrepreneur and the physician in practice, how do we get there? How do we engage some of that thinking?
So yeah, this is a big thing because I went through medical school when evidence-based medicine was just really gaining some momentum, and now it's like in orthopedics it's really coming in quite strong. But I'm actually starting to question it because the changes that we're trying to measure, the tools we have to measure those changes are like they're just so rudimentary. Is one of the problems. And so if we're talking about pay for performance, I think a lot of doctors don't trust it, and there's a good reason for that, because the measurement tools are really like very blunt. And that's one of the reasons I wear one of these. Like, this is not our device, and however good or bad that is for marketing. But okay. I wore 2 of these to see how good they were at measuring sleep, because if you've had shoulder pain, shoulder problems, sleep is one of the huge issues. If I want to endear myself to a shoulder patient and show them that I have some understanding of what they're going through, then I just say, how's your sleep? And I know what it's like. You wake up all the time. And we've never measured that, actually. And we've never measured whether what we do, injections or surgery, anti-inflammatories, physiotherapy, have any benefit on that at all. Right. I know that patients value that, though. And the bottom line is that we don't really define value in medicine. And it's because doctors aren't very good at that. And you're talking about things, my wife's a PhD student at Shirlee School of Business, and doing organizational studies, and I hear about institutional theory, things like that, but most of the people, I'm just learning about that, and I did an MBA. You know, I had some of it, but it's not a function that we really have in the healthcare system very much. Maybe I'm wrong, but I think that it's very rare, and doctors definitely don't have it. And if they have any say in anything, then it's going to be, you know, difficult to sell that sort of stuff because there's a disbelief in that area too. And qualitative studies, very rare in medicine, but very powerful actually. You know, to actually properly figure out the themes and what people are saying, to properly figure out what people really value and how often those things come up. So I'm totally with you. It's just I think that nobody's willing to accept that. And I can say that in trying to publish some stuff on that sort of stuff. Very difficult.
Yes,
very,
it is.
very difficult.
Yes, I share your pain. I would just ask that people think about the behavioral and the cognitive side of decision making and how we can incorporate that in much more broadly into the work that like all of you are doing and all of the work that's being done in transforming the healthcare system. There's so much good work out there being done. It is a pain to try and get it published, but there's some out there. Thank you.
Shirlee, did you want to take that on? And
I was just going to say you're absolutely right. It's huge. Why is it huge? It's because what we're providing is a human service. So you're absolutely right. It's anchored there. When you ask, you know, what are the issues? The short answer, history. History with the preoccupation of structures and institutions, politics, and quite frankly, in the past, we had enough money to mess around with it. Now, all of those things are changing. History, people are more informed, aware, and understand. De-physicalization is the latest thing, where location is irrelevant to what you can get. And I think we're running out of money. So I think that at this moment, it's probably the most exciting time to actually be in healthcare. And it's not necessarily for all the right reasons, but it really will start to move into, I think, a different and more holistic approach.
thank you. Tiziana.
I'm just going to add just one piece of that from an acute care perspective, because we're not all that bad. I think that there are pockets of really good work around cardiac rehab, chronic disease management, diabetes. It starts perhaps in acute care, not in the same way that it does in clinics for patients to go to that are run by dietitians and nurses and therapists that support patients where they are at from a behavioral perspective, doing also with the pharmacological management, all of that, and integrating all of the management strategies in those pockets, but we don't do it very well. We don't do it very well in acute care in a systematic and proactive way. I agree.
So one of the other things I'll just throw in for good measure is and Jesse raises this as well, health systems actually don't measure health behaviors and outcomes that matter to people. They measure, I know that's a walk on the wild side, they actually measure how productive, efficient, safe, accessible healthcare is. So they measure the system. We're not so terrific at measuring the outcome. So once we figure out how to measure those outcomes and what people value, what they want to achieve, then all of a sudden you get a very different mindset coming to those clinic appointments, whether it's Jesse's clinic or a home visit for Shirley's organization, because now you're actually being asked to achieve very specific outcomes, usually centered and decided upon by the individual, and that takes all the disciplines. And the other piece, I think, is, to Jesse's point, there aren't very many sociology, psychology, philosophy courses last time I checked in medical school. There's very few of them in nursing, pharmacy, social work, and others. So in some ways, we don't exactly prepare our students to walk out into the healthcare world of innovation really well prepared, I think, to take on some of these very fundamental issues. But to Shirley's point, the burning platform, to borrow a term from a business school, is very much upon us. And there is no time like the present to actually figure it out. So can I invite a few more comments from the panel? And we'll wrap up this session in about 4 or 5 minutes. Any other concluding thoughts as to, let me ask you the tough question. If Ontario's health system was to do 3 things to get to a very innovative, dynamic system that delivers value, to the Ontario citizens we are mandated to serve? What might those 3 things be?
I can give you one.
Okay, Shirlee, be brave. 1 out of 3 is not bad.
And it would be a different starting point. And let the starting point be where people are at and what they're looking for. Where we typically, you're right, you know, funding, productivity, what we're doing. Change things over to a very different starting point. And forget about us integrating our system. For example, start with what does an individual's life have and their journey, and how would they interact with us and intersect with us? It would force us to look at things very, very differently than how we come up with solutions and what we think we need before we really generate the right starting point in people's lives.
Tiziana.
Yeah, that's because we're nurses. Truly, I was thinking the same thing. We're going through this ourselves. It's just understanding the patient voice. What are those issues that those patients come in with? We had the highest number of patients with heart failure coming through our ER, highest number of patients, pediatric patients coming in with asthma issues. Those are the life experiences, and we look at them and we say, oh my goodness, how many visits in the ER and length of stay, and we use different data, to your point, where it's not connecting. Understand patient's voice, start with it where it is, and it's not about what are we going to do next. It truly is. It's got to be a multi-pronged approach to this. It's not a silver bullet that's going to make this make it work, but it does start with that patient voice, helping guide us to guide them to where they need to go. So that's
so from the nurses on the panel, before we move to the dark side called industry, because oh, you want to add another one?
I have a second.
Oh my goodness.
My second is embrace the entrepreneurs. Embrace people outside of healthcare.
She saved us.
Once we know the answers.
That answer.
There we go.
Yeah.
What an entree.
Of course,
I mean,
I like that
really,
answer.
it doesn't get any better.
Just a follow-up to that, take some risks. And we need to lower the cost of taking those risks.
Yeah.
I think
Fail early,
that's
fail
key to the
cheap.
system.
Yeah.
Fail early, fail cheap. That's right.
Gary, 2, 3, or 1? Pick it in terms of a solution.
I'll ladder on Shirlee's. I think you not only embrace the patient, but you embrace the informal caregivers that are in the market. There are, I think the number is $700,000 in lost income in a lifetime managing for your folks. You're the government. Maybe you could recognize that they're on the team and enable them. The specialist had 11 years to learn this. So get it into the community, which is what they're trying to do with their funding, but in a practical way.
So build community capacity to recognize all of the capacity in communities to actually mobilize and support people to stay healthy.
Yeah, and maybe to contribute and not lose income or get tax credits, whatever it takes to recognize that you already have several million people on the team that you're actually disabling, not helping.
It's interesting, there's 7 million Canadian women around the age of 46 to 47 years old caring for aging parents and children at home simultaneously, and they'll care for their parents more years than they'll have children at home. So I think that speaks to that point. Jesse.
Yeah. So I think the first thing is to avoid just coming up with solutions or advising solutions by entrepreneurs that sit on top of our current healthcare system as sort of a Me Too innovation. I think we got to think a bit about disruption, and that's one of the major problems is that specifically when doctors are involved, because things are very comfortable and the income is very comfortable, it's very easy to start thinking about how things could be easier for me today rather than how things could be better for the system, for society as a whole. That's number one. Number two, just get people together and early. I think that's a great comment to actually say what are the problems and probably to have some patience at that. And I think that came out in the discussion here too, so that the doctors' voices and the administration's voices, the system voices are somewhat weighted against the patient voices because they're not always exactly the same thing. And sometimes it's very surprising. And the last thing is to understand, I'm specifically from a hardware point of view, understand the risk that there is in getting into Health Canada and getting into FDA, and to try to help companies like us who are avoiding that currently specifically to provide some value in the healthcare system without needing to go down a route of 3 years and a lot of investment in becoming a regulated device. Because I think that there's a lot of benefit that can come from unregulated devices and still be used in the healthcare system. And so that's my big pitch to anybody here from a system point of view, and my kind of advice on an entrepreneur level.
And Jesse gets the prize because he actually came up with all three of the solutions to the health system. So let me thank each of you. Not last, but you are like a powerhouse, Jesse. So let me express my personal thanks to each one of you for a very dynamic session. Thank you for joining us. I will turn this back over to Claudia.
Thank you, Anne. I would like to thank all of our panelists, Shirlee, Sharkey, Tiziana, Rivera, Sachin, Aggarwal, Gary Baksi, Jesse Shantz, and our moderator, Dr. Anne Snowdon, for an excellent and very engaging discussion, and a discussion that covered a multitude of perspectives, from clinicians to healthcare provider organizations to patients as consumers, to SMEs, to startups. And I think really what this discussion shows us is that there is not only a willingness, but a real desire and an energy around potentially collaborating together across all of those different constituencies to develop some new and innovative initiatives in the province of Ontario. So we really appreciate the panelists taking the time to be with us today, and as a token of our thanks, we'd like them to accept a small gift and gesture, which is off to the side because I'm not sure I'm supposed to hold all of those at the same time. So thank you very much to our panel. And next in this theater is the Open Innovation, the executive sessions, starting in 15 minutes. Amin Sayani, Director of R&D Alliances, will speak to how GlaxoSmithKline is innovating and collaborating. So thank you to our panel, and welcome to Discovery again.